Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah, salatu wassalamu ala rasulillah. Alhamdulillah, thank you very much for my opportunity to come here. Professor Salman Sarif and Professor Zilali, thank you. And I want to talk this about pelvic parameter and that degenerative deformity. I think we recognize with this picture, 58 years old with axial pain and a sign of a claudio intermittent. My objective in this talk is actually I want to talk about the pathophysiology, natural history, problem related with degenerative deformity and spinal balance and pelvic parameter. But maybe in many things in pathophysiology and natural history, I will skip it. But the classification, Chris Shafrey said that there is adult degenerative de novo spinal deformity and also progression of adolescent idiopathic scoliosis and then become adult deformity. And iatrogenic deformity because of the stabilization and primary sagittal deformity. This is pathophysiology because of asymmetric loading, asymmetric degeneration, and then this is coming from Kirkcaldy-Willis stage 3. There are degenerative disc disease and spinal canal stenosis, and the deformity is rigid, and many times we found about osteoporosis. And the important from natural history is risk of progression is more than 30 degree. If more than 30 degree, there is a risk of progression, and the incident low back pain no difference than the contrary. Of course, there's a progression of lumbar curve. If we have a serial of the photograph like this, so we must think about it in the future. And the problem with this, the pathology is relatively rigid curve and some neurological concern and osteoporotic spine. And many times sagittal balance is lost and comorbidity like diabetic and hypertension. So it makes a high rate of complication. I skip this one. The important for sagittal treatment is we should think about balance states, and for the revision of malalignment, we should regain the sagittal and coronal balance, and if we need, we maybe do some osteotomy. And this is the pelvic parameter. The concept is if someone have a normal pelvic parameter, it will create the balanced spine. So our aiming of our surgery is how to make as normal as possible the normal pelvic parameter. This is the normal range of the pelvic parameter, like a pelvic incidence, sacral slope, pelvic tilt, and lumbar lordosis. And of course, this is different for everybody. Because of the regional lumbar lordosis, a part of global spine balance. So the restoration of lumbar lordosis is very important to make accomplishing a balanced spinopelvic alignment and corrective surgery. Like this one, this is how powerful the T-lift to regain the lordosis of the lumbar, because we know that 60% for the lumbar lordosis is coming from L4, 5, and S1, like this. And also the power of the cage we put here and the T-lift, so we can create the more lordotic for the L4, 5, this one. And also we will see for the L3, 4, the the lordotic and the discus is better than without without the T-leaf gauge. The issue of osteoporosis, we may put some cement augmentation inside with the screw, inside the screw, and also the above or below of the vertebral body. It will prevent somewhat from proximal junctional kyphosis. And also, we should know that surgical treated, it will improve significant from the patient score for leg pain, and but actually the major complication rate is 20% more. This is the first case, adult kyphoscoliosis. There is a cup angle 17 and kyphosis is minus 39. And we think that we should do some osteotomy, Peterson osteotomy and pedicle subtraction osteotomy, just like that. And from here, we can imagine that post-operatively, how many angle we can make improvement. So this is the final operation after operation. And the second case is this, the female 66 years old with axial pain and claudicosis intermittent. There is some kind of problem in alignment, and of course, some nerve compression. And alhamdulillah, that this is from osteoporotic BMD still good. And we must predict the progression because we will think about the stop. We must stop at the L2, L or 3. This is very important because as short as possible our instrumentation, it will be better. And this is Dr. Kobayashi makes some proposal that A per B, if this is less than 80%, it will positive asymmetry, and it should include in the construct. So like this, that A per B is 18, more than 18, so this is less likely become glacier instability, and we will stop in the L3, and we put cages here, and we create the lordotic and the lumbar part. Of course, this is it's scoliosis like this. And what we do that we make release and the facet joint, and we make instrumentation from T10 to the sacrum. I think like this. The conclusion is that the preoperative pelvic parameters should be considered to achieve post-op balanced spine alignment. Thank you.